All right, so it's wonderful to join. I am a caregiving scientist, a clinical psychologist by training. I study family caregivers, and I'm also a family caregiver. And today I want to tell you about some of the most important lessons that I've learned as a result of my experience as a family caregiver for my father who had Lewy body disease, as well as my experience over the past 15 years as a caregiving scientist. I want to acknowledge I do receive funding both from Blue Note Therapeutics in Beijing, though that funding has nothing to do with anything I'm speaking about today. I always like to ground my talks in the words of former First Lady Rosalind Carter, excuse me, with which you're likely already familiar. There are only four kinds of people in this world: those who've been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. This is a role that touches us all, often repeatedly throughout our lives. Now, the COVID-19 pandemic shined a bright spotlight on a national caregiving crisis in this country, one that predated the pandemic, but was exacerbated as a result of the profound responsibilities placed on our shoulders as family caregivers. The pandemic also highlighted a mental health crisis, one that similarly predated the pandemic, but was worsened by the individual and collective isolation and trauma experienced by all of us. And falling at the intersection of these crises are family caregivers, a group who's always been in incredible need for support. But long before the pandemic, the needs of caregivers were very much in the heart of our social media. In fact, I took a look at the articles from the New York Times in the few years preceding the pandemic, just to see the articles published on the topic of family caregiving. And these titles I'm going to share with you right now are maybe 1/10 of all the titles I found. A shortage of caregivers. More caregivers are no spring chickens themselves. Daughters still are the caregivers. Caring for the Alzheimer's caregiver. Who will care for the caregivers when the caregivers need healing? A living wage for caregivers. For some, the trauma lingers. A millennial caregiver. My family cared for my sick aunt. Who's caring for us? At 75, taking care of mom, 99. We did not think she would live this long. Pressed into caregiving sooner than expected. Caregiving's hard enough. Isolation can make it unbearable. Strategies for long distance caregiving. Medicaid patient shift squeezes home caregivers. Training needed for home care is lacking. Daughters will suffer from Medicaid cuts. Caregiver plus MD or RN. Caregivers sometimes must sacrifice their careers. And my all-time favorite, how getting high made me a better caregiver. Now, these titles speak to the range of challenges faced by family caregivers and those that we as healthcare professionals and myself and my colleagues need to address. From the financial toxicity of caregiving, to the fact that so many of us are providing care from a distance, to the reality that the distress associated with caregiving does not end with the death of the patient. So what do caregivers do? All of you in this Zoom room know the answer, and the answer is everything. Caregivers provide instrumental support, helping patients to navigate their daily lives. Activities of daily living, instrumental activities of daily living, ranging from the mundane to providing medical and nursing tasks. Caregivers provide emotional support. And very often this is at the same time when they're no longer receiving the type of emotional support they once did from patients. And so there's a mismatch in support that's received. On average, caregivers provide care for 8.3 hours a day for 13.7 months. This is a full-time job, often conducted in addition to full-time paid employment. And recently, at the end of 2023, the annual economic value of our efforts as family caregivers was estimated at $600 billion. It's an incredible amount. And despite this fact, up to 1/4 of us experience high financial strain. I bet you all agree with me when I say that we as family caregivers are critical to our healthcare system. Now, not surprisingly, as a result of these responsibilities, many caregivers experience mental health challenges, and all caregivers experience distress and burden in some capacity. This includes anxiety, depression, even post-traumatic stress disorder. Yes, caregiving can be traumatic. Many caregivers report insomnia as their most distressing symptom. And in fact, not being able to sleep is oftentimes caused by caregiving, but then of course makes caregiving a lot more difficult. This is something I experienced and something I've written about in my recently published book. It's important to acknowledge that the distress associated with caregiving can be severe, including suicidality. And as I mentioned, distress doesn't end if our care partners die. And many of us experience what we call prolonged grief, grief that is not resolving over time. Now, very importantly, distress doesn't just fall into these categories of anxiety or depression. There's also a category that we call existential distress. And this has been a focus of much of my research over the past 15 years, because I realized that so many caregivers I was seeing in my own clinical practice were not meeting criteria for full PTSD, but instead had this existential distress, which is the distress that we experience when we realize that we're mortal and that we and our loved ones will all die. And the caregiving role elicits existential distress and can manifest as feelings of hopelessness, a loss of meaning and purpose, a loss of sense of self. So many caregivers say they feel like they don't know who they are anymore, or they cannot plan for the future. Many feel like they're a burden to others. And this existential distress is very much a driver for the experience of many of us as caregivers. Now, importantly, when left untreated, this distress, all of it, can increase exponentially across the caregiving trajectory. Now, this is a typical cancer caregiving trajectory. I have this here because I work in a cancer center, but we can extrapolate to other illnesses. But what I really want to highlight for you right now is one of the lessons that I've learned in my work as a caregiving scientist. And that is that, of course, distress increases for us as caregivers if our care partners, our loved ones, if their illnesses are not able to be treated, if they transition eventually to hospice care and we into bereavement. That, of course, is a difficult time. But I actually want to highlight an earlier point in this trajectory, and please forgive me, treatment shouldn't be in red, it should be survivorship. Survivorship is a period when, for many of us, for many patients, they have stopped their treatment and they take an exhale. Perhaps they're able to return to life, to work, to their quote unquote new normal. This is a time in patients we often see a decrease in distress. And yet, for us as family caregivers, we often experience a significant spike in distress. And this is likely because during the initial phases of our care partner's diagnosis and treatment, our going for first and second and fifth opinions, we're in fight or flight mode. We can't take a pause. But when we do take that pause in survivorship, there's a rushing in of all the negative emotions we were avoiding during the initial phases of our loved one's diagnosis and treatment. And we actually see a significant spike in distress in caregivers in survivorship. And I'm sharing this for two important reasons. I want to normalize this for you. If you're a caregiver and your care partner is doing better medically, and all of a sudden you're not feeling so great, that's actually very normal. And second, this is a moment that we as family caregivers and patients become disconnected from the healthcare team. But at the same time, this is a moment when we as family caregivers need support. In 2011, at Memorial Sloan Kettering Cancer Center, I founded the Caregivers Clinic because I realized that family caregivers were experiencing profound distress, were increasingly asked to take over responsibilities held once only by trained healthcare professionals, and that there were no targeted support services for family caregivers in any cancer center or any hospital system in this country. And the mission of the clinic is to assure that no cancer caregiver experiencing significant distress goes unidentified and deprived of necessary support. These data are just to give you a glimpse of the number of caregivers we've seen. This is from 2021. These data are outdated, but you can see we've had 408 caregivers at that point, over 500 at this point come to receive support in our program. And we provide support to caregivers of patients with all sites and stages of cancer, from diagnosis through bereavement. Caregivers can receive medication management if they need it. And we also provide family and couples and group psychotherapy sessions. I think more importantly and interesting to this audience than my clinic is what's happening in this country. And I'm curious what your own experiences have been in terms of being offered support. My colleagues and I during the pandemic conducted a study to see what support programs were available in cancer centers across the country. And we defined a support program, caregiver program, as anything from the program that I've established at Memorial Sloan Kettering, which was the first of its kind, to simply giving caregivers referral to the community or an informational packet. And what we found was among 238 cancer centers, 75% said they had a program. However, the most common program was simply giving caregivers a pamphlet or referral to the community, not actually providing support. And I flip that number around and I think to myself, well, 25% of cancer centers don't even have that. That is unacceptable. And I am on a mission to change that. And I'm working right now to take the model of care that I've developed and to replicate it in cancer centers across the country and then eventually across healthcare systems. I want to turn now to the lessons because that's really what I'm here to talk about today. I wanted to share that the same year I began the clinic in 2011, I became a caregiver for my father, as I mentioned, who had Lewy body disease. Lewy body disease is a progressive neurodegenerative disease that leads to fluctuations both in autonomic functioning and consciousness. In my dad, he would have sudden drops in blood pressure and temperature to near hypothermia levels, and he would hallucinate. He'd hallucinate anywhere from a few minutes to a few hours, occasionally up to a day, and one point an entire week. And we never knew how long the hallucinations would last. They were often precipitated by illness, urinary tract infections, UTIs, by dehydration, but we never knew when they would end. And I experienced each one of those hallucinations as a mini death. I took care of him for a decade. A year after his diagnosis, my mother died suddenly. So my caregiving journey was punctuated by my own trauma and loss. And at the same time that I was navigating our healthcare system, getting him onto Medicaid, securing home health care, I was also building this clinical service. And I share that because I speak to you not just from the lens of caregiving science, but having such an intimate experience in caring for him until 2019. So the first lesson that I want to share is that caregivers experience shifting roles and family dynamics. My guess is all of you who are family caregivers have experienced this. This happens. The reality is that our relationships as parents and partners and children and siblings and friends, they change because of illness and caregiving. When we step into the respective caregiver and care recipient or care partner relationship, that changes. The romantic relationship dynamic changes, of course, when you're in a patient and caregiver relationship, as it does for a parent and child, parent and adult child. That's real. And what I want to label for you all is the word loss, because I think it can be very powerful to acknowledge the fact that the changes that we experience in our relationships are losses, whether that's a loss of physical intimacy in the context of a romantic partnership, or in the experience I had with my father, the loss of the capacity to communicate with him at all times, the loss of the ability for me to plan for our future. That was a loss. And those losses need airtime. They need to be grieved. Also important to acknowledge, you all know this, but caregiving never happens in a vacuum, right? We are managing patient care while also managing other caregiving relationships, childcare, for example, finances, the household, maybe even our full-time paid employment, because of course, as of today in this country, we don't have a robust paid family medical leave plan. And because we may be taking on responsibilities once held by our partner in care, the patient, that too impacts the dynamic. And so these changes in relationships happen, they're unavoidable. As such, it is so very critical for you as a caregiver, as you experience these losses and changes in relationships, to prioritize your self-care. Now, I know that self-care is a phrase that perhaps has made some of you roll your eyes. I'm one of those people who rolls her eyes when I hear self-care. It's a phrase that gets thrown around a lot. And something I write about in my book is that I am not a fan of that oxygen mask metaphor. I find it incredibly invalidating, especially if you're in the thick of caregiving and someone says to put on that oxygen mask. Well, we all know you can't put it on in a crisis. And we all know that if we could put it on, we would. When I think of self-care, to me, this is about energy, preserving energy. We as family caregivers do not have a limitless supply of energy. And so self-care is anything that you do to preserve your energy. And that might mean cutting people out of your life, saying no to spending time with certain individuals who don't support you, who don't buoy you up. You need to protect your energy. That is self-care. All right, the second lesson is that we as family caregivers are responsible for case management. Now, case managers are by definition paid employees of healthcare systems who coordinate care. But we as family caregivers, no surprise, are asked to do this without pay. And again, our efforts were estimated at $600 billion. Now, these case management responsibilities can be profound. For me, the most overwhelming element of my case management responsibilities was getting my dad onto Medicaid and securing home health care. This was an incredibly complicated journey for me, one that was way more complicated than getting my doctorate in psychology, and something that I've written about because I want to demystify the experience. I have an image on the slide of a telephone because for so many family caregivers, case management responsibilities means spending a lot of time on the phone, a lot of time on hold, which is very, very frustrating. And this, of course, means that you need to be making phone calls during daytime hours, which is particularly difficult if you're also trying to maintain paid employment. This is why, for example, being able to take off short times from work via the Family Medical Leave Act, for example, can be beneficial. But what I want to highlight not only are that these responsibilities come as a surprise, I had no idea how overwhelming these responsibilities were going to be for me. But on the flip side, that these are the responsibilities that often can be most easily delegated. It's so much easier to delegate these to an extended network of family and friends than to delegate the hands-on caregiving. And by the way, delegating, having others help with caregiving is, of course, a key element of self-care. None of us can do this alone. And as I say that, I imagine some of you are saying to yourselves, well, I'm the only person available. The reality was I was the only person available. I was my dad's primary caregiver. My mother died. I had no one else to really help me day to day. But I learned that I could not do it alone. I needed others to help, and I had to ask for help, and I had to delegate. So I encourage you all to do the same. The third lesson, which came as a surprise to me in terms of the magnitude of responsibilities, was that we as family caregivers are asked to perform medical and nursing tasks. And our responsibilities are only increasing exponentially and are going to continue as care moves out of the hospital and into the home. We are not wearing white coats. We are not carrying pagers, but we as family caregivers are absolutely critical members of the healthcare team, actually taking on responsibilities of healthcare. You know, I was asked to change my dad's suprapubic catheter bag, to clean the opening to his bladder, clean his wounds, take care of his bed sores, and give injectable medications. These are all tasks usually performed by trained healthcare professionals. And quite frankly, what I was doing was on really the easy end of the types of responsibilities that my caregiver patients have shared with me. And my guess is that for many of you listening, you are doing way more complex medical tasks than I had to do for my dad. And I'm curious whether or not you received any training or education. And I ask that by also acknowledging that in this country, we currently do have public policy, one of the few, that supports us as family caregivers in our responsibilities in performing medical and nursing tasks. It's called the Caregiver Advise, Record, Enable Act, the CARE Act. I should have inserted a poll to see who's heard of the CARE Act. You could do that by voting later on. So the CARE Act is currently passed in 45 states and territories. it has 3 provisions. It says that your information as a family caregiver should be documented in the medical record of the patient at a time when a patient is admitted to the hospital. It says that you should be informed when a patient is discharged from the hospital or transferred to a different floor or setting. And very importantly, that you should receive instruction and training so that you know how to take care of your care partner when they go home. Now, the reality is that the CARE Act, even in states where it's passed, is inconsistently implemented. I certainly never received any of this training, even though it was effective in New York State at the time that I was taking care of my dad. But I want to give you a tip, something that has helped me and many of the caregivers with whom I've worked. Before you leave the hospital, if it's not offered to you, I want you to ask a nurse or other member of the treatment team for training and guidance and to demonstrate for you all the things that you're going to need to do to take care of your loved one at home. And then I want you to perform back for that nurse or other healthcare professional those tasks so that you feel confident and competent to do so at home alone. And then many patients are prescribed visits from a visiting nurse after they're discharged from the hospital. This was always the case for my dad. He would get through Medicare 2 weeks of visits from the Visiting Nurse Service of New York. I want you to consider every one of those visiting nurse visits not only as an opportunity for your care partner to be evaluated, but for you to brush up on your skills, for you to ask questions, for you to ask them to demonstrate again a specific skill, and for you to practice it back. I want you to use all of those visits to your advantage. So I mentioned case management and medical and nursing tasks, but I think the one responsibility that is most surprising and not often thought about as a responsibility is healthcare communication. Healthcare communication is really at the heart, the bedrock of what we do as family caregivers. We as caregivers are the missing link between healthcare professionals and patients. We are the hub of an info flow wheel that could not turn without us. We truly are a missing link in communication. And without us, there could be absolute chaos. I'm sure many of you have experienced that. Now, I want to acknowledge right off the bat that healthcare communication can be very anxiety-provoking, even for those of us perhaps who are trained in communication and communicate for our careers. And while all healthcare communication is important and can be anxiety-provoking, I want to acknowledge that our responsibilities as healthcare proxies for those of us who formally step into that role truly depend on communication. Because as healthcare proxies, our responsibility is to bring our care partner's voice into the room if there comes a time when they are unable to do so on their own behalf. And the only way that we can bring their voice into the room is if we know what that voice will say. And the only way we would know what that voice will say is for us to ask, to engage in communication. And I know that engaging in communication, especially about care in the future, about this umbrella term, advanced care planning, can be overwhelming. It can be overwhelming to talk with care partners because we don't want to upset them. Let's talk about this. We bring an elephant into the room when we talk about care in the future, and that elephant is death. And none of us want to talk about death. We want to maintain hope. And these conversations don't happen in a vacuum. There are pre-existing family dynamics and, important to label, conflicting prognostic understanding. And what I mean by that is many times what we as family caregivers understand about our care partner's prognoses is different from what they understand or what they say they understand. And that can make communication difficult. And it can be really difficult to talk to healthcare professionals. Let's be honest, not every healthcare professional opens conversations about care in the future. Many healthcare professionals have received no training in communication, right? They're great physicians and terrible communicators with terrible bedside manner, and they don't know the right words to use. And oftentimes healthcare professionals have difficulty opening conversations because they realize that the patient and caregiver standing or sitting in front of them are on different pages. So I want to give you 3 communication techniques that you can take with you today to help you in navigating communication. And throughout my book, I include many more. And the first is what I call the consent conversation. And this can help you and your care partner to get on the same page. Oftentimes, caregivers will say to me, I really want to talk to the doctor about what treatments might be available if this treatment stops working, but I don't think my husband wants to know the answer. And if you and your care partner are on different pages, you're never going to get information. We all know those visits happen so quickly. When we are anxious, it makes those visits go even faster. And so a consent conversation allows you and your care partner to get on the same page. This is something you're going to have in advance of the visit with the doctor. It might sound something like this. Dad, I would really like to ask your doctor what treatments are available if this treatment stops working. Would that be okay? And is there anything that you want to bring up with her? Now, my dad could have said, no, that's not okay. In which case I would have said, all right, I'm going to ask you again before the next visit we have. Now, one situation where the consent conversation is particularly important is if you're in a situation where you are concerned about the health-related behaviors your care partner is engaging in. And by health-related behaviors, I mean their alcohol use, smoking, exercise, whether or not they're taking their medications. And we all know sometimes patients don't like to tell their doctors the reality of their behavior, but these behaviors very much impact their health. If you're concerned about this and you want to bring this up with the doctor, but you know your care partner might not want that, you can use the consent conversation, and it might sound something like this. Babe, I'm concerned about how difficult you're finding it to remain adherent to your medications. I think it's important your doctor knows you aren't taking them regularly. We mention this to him next week. Again, your partner could say, no, don't say anything. And then you'll say, all right, but if it doesn't change, I'm going to have to ask you again before our next visit. The second communication technique is called setting the agenda. And setting the agenda is particularly helpful if you are anxious about opening a conversation about advanced care planning, goals of care, care for the future. Setting the agenda allows you to put out on the table what it is you want to talk about and why. And it's something that you can practice in advance of the conversation so you can feel confident to have that conversation. Setting the agenda sounds something like this. Dad, I know this is really hard to talk about, but I would really like to discuss what type of care you would like to receive in the future should this treatment stop working. It's important for me to know what you want so that I can be sure to carry out your wishes if you can't tell the doctors what you want at that time. Can we talk about this? Now, what I want to really emphasize right now is that this is not a conversation you're going to have once or twice. This is a conversation you're going to have repeatedly because goals of care change. What my dad wanted for his care in 2013 was dramatically different than the care he wanted in his last year of life in 2019. And had I not had repeated conversations about goals of care, there would have been no way for me to know that his goals of care had changed. So asking multiple times, having these conversations repeatedly is a must. I also want to acknowledge that communication with other members of the caregiving network can be challenging. And I encourage you, if you want to air a grievance, to do so using the XYZ technique. It goes like this. I feel or felt X when you say or said Y because Z. So for example, perhaps your cousin isn't participating as much in caregiving as they said they would. You might say, I feel really frustrated when you don't show up to the hospital once because I've been there every day for the past month. And then I encourage you to follow your XYZ technique communication with an ask. Would it be possible for you to visit for the next 2 days so that I can have a break? All right, lesson 5, I want to keep going. We know, all of us know that we as caregivers must cope with many negative emotions. Every word on the screen is a word patients have told me again and again and again. These are all feelings I have felt as well. We as caregivers have many, many worries. These are many I hear in clinic. The look on the doctor's face meant something bad. He seems more out of breath. The cancer must be back. And these worries are understandable. What I want to emphasize to you, maybe one of the most important lessons, emotions are messengers and they tell us how to live more fully. As a clinical psychologist, I will never tell you to avoid your emotions. I will tell you to learn from them. And I want to give you some tips today for 3 emotions that are likely common among all of you joining. The first is anger. Now, you have every right to be angry if you're a caregiver, if your life has been put on hold, if your dreams have been deferred, if you're no longer able to plan, you can't plan for the next year or the next month or the next week or the next day or the next hour. That's maddening. And that anger needs to come out. But I want to highlight the fact that beneath anger, there is often a deep well of sadness. It is a lot easier for us to feel anger than sadness. In fact, very often in my clinical practice, caregivers who express anger oftentimes then end up crying. And we often identify the fact that they are grieving a loss in the relationship. So the next time you feel anger, I want you to ask yourself, what am I grieving? It could be a big loss, a small loss. You could be grieving the fact that your care partner can no longer do the errands and the things around the house they once did. But if you allow yourself to express the sadness, connect to it and grieve and let that out, your anger is going to dissipate. The second example is disgust. This does not get enough airtime. Let's be honest. There are elements of caregiving that are disgusting. It can be disgusting to change an adult diaper. It can be disgusting to change a colostomy bag. It can be disgusting to clean a wound that has a strong odor. Now, feeling disgust is normal and adaptive, but what I hear in my clinical practice that isn't helpful is judgment. And I'm wondering if any of you have ever judged yourselves for feeling disgust. I know I have. It's something I've written about after taking care of my dad and changing his diaper. I was so angry at myself because I felt disgust. I was thinking, God, I should be so glad that he's alive. How dare I feel disgust? But what I want to encourage you to do is something I did that night in particular. I want you to ask yourself, if my best friend was watching me right now perform this very difficult act of caregiving, what would they say to me? Would they judge me? Or would they perhaps more likely say, wow, you are a superhero. You're incredible for doing that. I want you to challenge the voice of your best friend in those moments. And the third example is guilt. Couldn't be a talk on caregiving without guilt. One of the most common feelings I hear in my clinical practice, we feel guilt often. And I know caregivers feel guilt when I hear thoughts that start with I would or should or could. When we feel guilty, we feel like we are letting someone else down or we're about to let someone else down. Caregivers will say to me, Dr. Applebaum, I shouldn't be here. I'm not the patient with cancer. Dr. Applebaum, I shouldn't be here. I should be at his bedside. When we feel guilt, we feel like we are doing something that is letting someone else down, but that's wrong. When we feel guilt, it is a sign that the person we are or about to let down is not our care partner, but ourselves. Guilt is a red flag. It tells us we're going in the wrong direction and we need to turn around. The next time you feel guilty, whether it's about caregiving or anything else in your life, I want you to ask yourself, if I continue to do this thing, whatever this thing is, am I going to let myself down in some way? And instead ask yourself, what can I do to meet my own needs? All right, so caregiving, negative emotions, that's all real. But what I want to end with lesson 6 is that despite suffering, caregiving provides us with an opportunity to connect to meaning and purpose. And I want to preface this with, I am not talking about the power of positive thinking. I'm not talking about turning lemons to lemonade. That's not who I am as a person or as a therapist. But what I am talking about is that suffering and meaning can coexist. Now, I have a picture of a creme brulee on the screen. Creme brulee is my favorite dessert. For those of you who are not creme brulee aficionados, when this dessert is done properly, it's crispy on the outside and it's creamy on the inside and it's cold on the inside and it's hot on the outside. And when you take that first bite, There is so much going on. This is how I think about the emotional experience of caregiving. At any one time, we can feel sadness and fear and disgust and anger and love and hope and strength. The suffering and the meaning can coexist. They don't negate one another. And there are typical pathways through which we can connect to that meaning. We can connect to our authentic sense of self. Yes, caregivers say, I don't recognize myself because I'm no longer able to work full time or do the things I once did. But caregiving doesn't change who we are authentically in our core. And if you feel like you've become disconnected from yourself, I want you to answer the question, who am I? And I want you to ask yourself that question from the vantage point before caregiving. And then I want you to see how in any way you can reconnect to that part of yourself while you are a caregiver. We all can do it, even in small ways. Caregiving doesn't happen in a vacuum. There's a historical context. Maybe you had models of caregiving. You saw parents or grandparents take care of family members. That taught you about caregiving. And it's important to recognize that your caregiving role is a part of your own legacy. It's a part of who you are now. It's a part of how people see you and will always think of you moving forward. And that can be powerful and meaningful. We can connect to meaning by reflecting on how we face the challenges and limitations with which we are faced in caregiving. Now, look, most of us feel like we don't choose to become caregivers. I certainly didn't feel like I had a choice, but we do have choice over how we face the day-to-day, even in small ways. Every day that I went to work and put my phone away just for a half an hour, that was my attitude. That was my choice. That was my goal of connecting to my identity as Dr. Applebaum, to feed my soul so that for a half an hour, I could put aside my identity as Allison, the caregiver of Stan Applebaum. I want you to think about how you are choosing to respond to caregiving. And my hope is that you might even feel some pride in how you're doing so. And perhaps appropriate given the picture of a creme brulee, we can connect to meaning through our five senses. Yes, through taste, touch, smell, hearing, what we see. We can connect to meaning through a tight hand, hold, or hug. My dad lost most of his faculties towards the end of his life, but just holding his hand or lying on his shoulder was the greatest medicine for both of us. If you're stuck in the hospital for hours, I encourage you to do everything you can to leave for a minute and feel the sunshine on your skin and take a deep breath and connect to the feeling of nature. That is meaning. Or put in your earbuds and listen to your favorite song and be transported to a different time and place. It doesn't take away from the suffering in front of you, but it can provide you with a reconnection to meaning. Now, I just want to acknowledge, of course, that there are certain questions we can ask ourselves, that you can ask yourselves to help you to connect to meaning. All of these are in my book with many others. These are some food for thought. In what ways has your sense of identity changed as a result of caregiving? What have you learned of yourself, about yourself as a result of caregiving? You know, I have lost track of the number of caregivers who said to me that they had no idea how strong they were until they became a caregiver, or they found their voice because of caregiving. And my guess is that many of you have also had some changes. I'm Allison 6.0 speaking to you today, a much different version of myself than the one who began her caregiving journey over a decade ago. Are you proud of being a caregiver? Why or why not? I hope you are. Since becoming a caregiver, what are the specific limitations or losses you faced, and how are you coping with them? This is about your attitude. And what are your responsibilities, and who are you responsible to and for? And boy, I really hope your name is on that list. I just want to acknowledge, of course, as a psychologist, it's important to ask for help and get support. It's always a good idea to speak with a social worker attached to your care partner's medical team. They often know where to find support if they can't provide it for you. Definitely request a community referral if the hospital where your care partner receives support, if they don't have support for you, they always or most often have those referral lists to the community, so use them. I love the website psychologytoday.com. You can put in your name and your location, your location, not your name, your location and your health insurance information, what you're looking for, and you can find therapists in your area. great, great resource. Of course, many religious and spiritual institutions offer support. And finally, peer support is also wonderful. I think this community being brought together today is an incredible opportunity for support. We as family caregivers can certainly support one another. I hope that you have felt supported by me in this talk today. Please do stay in touch. You can find me on the social media places and on my website. I hope you'll take a look at my book. It provides you with a Cliff Notes version of all the type of support you would get if you were to come to our clinic at Memorial Sloan Kettering Cancer Center. I talk about as well my own personal journey. It's been such an honor to join you. I'm looking forward to time for Q&A. Thank you so much.
Thank you, Dr. Applebaum. We're going to go right into the Q&A now. So question, how can caregivers identify when they need to take a step back and prioritize their own needs over those that they are caring for?
Great question. Like, when do we know, right?
Mm-hmm.
We know when we can't sleep at night. We know when we feel like we are no longer able to carry forward all of our other responsibilities. Mm-hmm. And we know when we are finding it difficult to take care of our care partner. Those are three great signs that it is time, not just for more support, but for you to take a step back from caregiving. Whether that's a day, a week, even longer, taking a step back is needed.
That's great. What advice do you have for caregivers who may feel guilty or selfish when focusing on their own self-care needs?
I mean, this question couldn't be more planted, right? So I spoke about guilt, right? Feeling guilty for your own needs. That guilt, let's love guilt. I want to convince all of you guilt is a good thing, because when we feel guilt, and we are so good at feeling it, it is actually our mind telling us, Allison, you are neglecting me. You're feeling guilty because you're neglecting me. If you spend one more hour with your father, you're going to crumble. I want to flip the narrative, guys. I want you to listen to that guilt and say, it's telling me I need to take care of myself. I don't want you to get rid of the guilt per se. It's actually a wonderful thing. But I find that the more and more I actually do listen to that inner voice and I follow it, that guilt's going to get quieter because it's not going to need to be there.
Last one, how can organizations or communities better support caregivers in prioritizing their own health and well-being?
This is a big one. You know, I think we could spend a whole 45 minutes on this topic.
Could have been another session.
We could do another session on this. Number one, identifying caregivers, right? I think so many organizations don't realize how many individuals within the organization are identified as family caregivers. And then number two, understanding what the unique needs are of those family caregivers. I think this is so much the work that I'm going to be doing moving forward, is helping organizations to better meet the needs. But I think it all starts with identification.
Well, thank you very much for presenting with us today and being here with us.
My pleasure. Thank you so much.
Thank you so much.